Welcome to another episode from the Veterinary Medicine Digest. Imagine prescribing a completely standard, widely accepted dose of a relatively safe seizure medication as an add-on therapy for a poorly controlled patient.
Right, a scenario we see basically every week in the clinic.
Exactly. So the owner takes the dog home, they administer the pills exactly as directed, and 3 weeks later, the dog is carried back into your clinic profoundly ataxic, severely sedated, and just plunging into acute liver failure.
Which is an absolute nightmare for everyone involved. I mean, especially the clinician.
It is a nightmare. But here is the terrifying part, the thing that really gets you. It wasn't the new drug that poisoned the dog.
Yeah, that's the twist.
Right. The new drug silently manipulated the patient's liver enzymes, basically trapping the dog's original medication in the bloodstream until it reached these massive toxic concentrations.
It's a classic pharmacokinetic trap, and it catches so many people off guard.
It really does. And so today, we are undertaking an intensive evaluation of canine idiopathic epilepsy, specifically looking at a medication that has historically been, kind of relegated to the bench.
Yeah, definitely kept as a backup.
But now it's actively rewriting the rule book in veterinary neurology, and we're talking about Zonisamide.
Yeah, Zonisamide, which, for years our community has just relied on phenobarbital and potassium bromide as the absolute first-line gold standard therapies.
Right, those were the heavy hitters. And Zonisamide was treated as a second-tier add-on, like a backup plan you only deploy when the heavy hitters failed or, caused too much collateral damage.
Exactly. But this deep dive is taking us through a stack of new, highly relevant clinical data. Specifically, we're looking at the brand new Auburn University retrospective, which is paper allo0co26.pdf, and also the Prospective trial by Saito and colleagues.
Yeah, and we are digging into this data to answer two critical questions that, honestly, every veterinary clinician out there needs answered.
Number one being, is there robust, undeniable evidence to support Zonisamide as a monotherapy?
And number two, is it genuinely safe when it stands alone?
Right. Because the landscape of anti-seizure medications, or ASMs, is undergoing this profound paradigm shift right now.
It really is. I mean, for decades, our prescribing algorithms have been incredibly rigid.
Oh, completely. They were largely dictated by what we knew best, right?
Right.
Rather than what might be biologically optimal for the individual neurology patient sitting in front of you.
Yeah, we just went down the standard flowchart. But the data we're looking at today forces us to critically evaluate assumptions the veterinary community has held since, the early 1990s.
It does. We have to really reevaluate the true clinical potential of Zonisamide when it's elevated from just a secondary adjunctive therapy to a primary standalone defense against these cortical electrical storms.
Okay, so to understand the magnitude of this shift, I want to look back at those historical gold standards that put Zonisamide in the shadow to begin with. We really have to talk about the 2012 Booth trial.
Ah, yes, the landmark Booth trial. That was our massive, double-blinded, randomized trial comparing phenobarbital directly to bromide as first-choice therapies.
Right, and the numbers from that study basically shaped a decade of clinical practice. Phenobarbital eradicated seizures in 85% of the dogs in that study.
Which is a staggering success rate, honestly.
It is, and bromide only achieved seizure eradication in about 52%. So looking at those numbers, phenobarbital seems like the undisputed heavyweight champion of seizure control, right?
It does look like that on paper, but the biological cost of that 85% efficacy is extraordinarily high.
Exactly. You're constantly managing the risks of hepatotoxicity, and then there's that phenomenon of autoinduction where the drug just accelerates its own enzymatic destruction.
Right, and we can't forget those unpredictable, devastating idiosyncratic reactions like pancytopenia. I mean, the phenobarbital dynamic is the classic double-edged sword in veterinary pharmacology.
It really is. Its efficacy is undeniable, and its pharmacokinetic profile is inherently stable, which is great.
Oh, the stability is a huge clinical advantage. It boasts a long elimination half-life, generally between 53 and 96 hours in dogs.
Which minimizes those dangerous serum concentration fluctuations between doses that can trigger breakthrough seizures. You miss one pill, it's not the end of the world.
Exactly. But the collateral damage to the hepatic system is significant, and it's insidious. Phenobarbital is a potent inducer of hepatic cytochrome P450 enzymes.
And this induction doesn't just clear the phenobarbital faster, leading to tolerance and you having to escalate the dose.
Right. It aggressively clears concurrently administered medications, too. It just turns polypharmacy into a complex mathematical nightmare for you.
Yeah, and beyond the enzymatic induction, the hepatotoxicity, even though it's often the result of chronic cumulative cellular wear and tear rather than like acute necrosis, it's the shadow that hangs over every long-term epilepsy patient we treat.
It's always in the back of your mind when you write that script.
So then you look at the alternative from that era, potassium bromide. And on paper, it sounds like the perfect solution to the liver problem because it bypasses hepatic metabolism entirely.
Right, it's excreted primarily via the kidneys, so the liver gets a pass.
But bromide's half-life in dogs is just massive and highly variable, spanning anywhere from 15 to 69 days.
Yeah, weeks or even months. And that half-life is heavily dependent on dietary chloride intake because, chloride and bromide compete for reabsorption in the renal tubules.
Right, so if an owner changes the dog's diet or gives them salty treats, or I don't know, the dog swims in the ocean and ingests salt water, the bromide clearance dramatically accelerates.
The serum levels plummet, and boom, the dog has a cluster of seizures. It's incredibly volatile based on diet.
Furthermore, because of that extreme half-life, if you have a patient actively seizing and you need to reach steady-state therapeutic levels quickly, you just cannot wait 3 months. You have to load it.
And the bromide loading protocol is notoriously brutal on the patient. I mean, the Booth study, for instance, utilized a 450 milligram per kilogram oral loading dose administered over 5 to 7 days.
That's a massive amount of salt.
It is. The physiological consequence of dumping that massive salt load into the canine stomach is severe gastric hypertonicity.
So basically, severe vomiting.
Profound, intractable vomiting due to direct mucosal irritation. In that very study, multiple dogs had to be completely withdrawn in the first week simply because the gastrointestinal distress from the loading dose was clinically unacceptable.
So clinicians were trapped in this frustrating dichotomy, like accept the creeping inevitable liver risks of phenobarbital, or accept the gastrointestinal nightmares and the dietary tightrope walking of bromide.
Yeah, it was a pick-your-poison scenario for a long time.
Which brings us to Zonisamide. It was synthesized back in the 1970s in Japan, originally investigated as a psychiatric drug, interestingly enough, before its anticonvulsant properties were really recognized.
Yeah, it's a sulfonamide-based medication. And when you look at its pharmacology, it seems like a neuropharmacological masterpiece.
Because it doesn't just target one receptor or one pathway, right?
Exactly. It has an exceptional multimodal mechanism of action.
Yeah.
It attacks the problem from multiple angles.
Okay, I want to break down what that actually means at the cellular level. We label it an excitation-inhibiting ASM because it blocks voltage-gated sodium channels and T-type calcium channels. But how does that specific blockade translate into stopping a seizure in a dog's brain?
Well, to understand the sodium channel blockade, we have to look at how a seizure actually propagates. During high frequency, repetitive neuronal firing, which is, the hallmark of an epileptic discharge neurons, rely on voltage-gated sodium channels to rapidly depolarize.
Right, they have to open to let the signal fire.
Exactly. Now, zonisamide binds to these sodium channels, but the key is that it specifically binds to them in their inactivated state.
Okay, so it prolongs the recovery time of the channel.
Yes, precisely. It prolongs that refractory period. It doesn't stop normal low-frequency action potentials, which is why the dog can still walk and function normally and not just be paralyzed.
Oh, that makes sense. So it's selective for the hyperactive stuff.
Right. When a neuron tries to fire at the pathological rapid-fire rate of a seizure, zonisamide essentially acts as a speed limit. It prevents the channels from resetting fast enough to sustain that epileptic discharge.
Okay, so that's the sodium channels. It's like a speed limit for the firing rate. What about the T-type calcium channels? Because I usually associate those with thalamic pacemakers and absent seizures in humans, not necessarily the generalized tonic-clonic seizures we typically see in canine idiopathic epilepsy.
That's a really astute observation. You're right. T-type calcium channels are low-voltage activated channels, heavily concentrated in the thalamocortical circuitry.
So what are they doing during a typical canine seizure?
Well, they are responsible for generating the burst-firing pacemaker currents that synchronize the cortex during certain types of seizures. And while true canine absence seizures are rarely diagnosed, partly because, frankly, they are incredibly difficult for an owner to recognize.
Yeah, a dog just staring off into space for 5 seconds. Most owners just think they're watching a bug.
Exactly. But we are increasingly realizing that thalamocortical synchronization plays a massive role in the propagation and generalization of focal motor seizures into generalized tonic-clonic events.
Oh, wow. So by blocking these T-type channels, zonisamide disrupts that abnormal synchronization between the thalamus and the cortex.
Yes, it effectively isolates the seizure focus and prevents it from recruiting the rest of the brain into a generalized storm.
That's incredible. So we have the sodium channels slowing down the firing rate and the calcium channels desynchronizing the network. But it doesn't stop there, does it?
No, it also impacts neurotransmitters directly. It actually inhibits the release of glutamate, which is our primary excitatory neurotransmitter in the brain.
While concurrently facilitating the release of GABA, our primary inhibitory neurotransmitter.
Right. It is literally hitting the brakes on excitation while simultaneously pressing the accelerator on inhibition.
Throw in its weak carbonic anhydrase inhibition, which slightly acidifies the intracellular environment, raising the seizure threshold, and its ability to scavenge free radicals to protect against excitotoxic neuronal death. I mean, it honestly looks like the perfect anti-seizure medication on paper.
It attacks the pathophysiology of a seizure from almost every conceivable biochemical and electrical angle. But, this multimodal brilliance makes the historical clinical hesitation surrounding the drug all the more intriguing.
That is exactly what I'm struggling to reconcile. If zonisamide is this neuropharmacological Swiss Army knife, why did the 2015 ACVIM consensus statement on seizure management in dogs explicitly give it a low recommendation as a monotherapy?
Yeah, that was a major roadblock for the drug.
I mean, the Body 2015 review looked at all the literature and concluded there was just insufficient evidence to recommend it as a standalone first-line treatment. Were they just being overly conservative, or did they see something in the data that we were missing?
Well, they were adhering strictly to the principles of evidence-based medicine, and that requires a firewall between pharmacological theory and clinical recommendation.
Right. Theory isn't proof.
Exactly. The gap between a drug looking brilliant in a petri dish or a rodent model and proving safe and effective in a large, heterogeneous population of client-owned dogs, that is a chasm that can only be bridged by rigorous, controlled clinical trials.
And we didn't have those in 2015.
We didn't. In 2015, we simply lacked large cohort, long-term monotherapy data for zonisamide. The hesitation from the ACVIM panel wasn't because the drug was proven ineffective. It was because it was clinically unproven.
Okay, that makes sense. I actually looked at the references they used for that 2015 consensus. The primary study evaluating zonisamide as a monotherapy for canine idiopathic epilepsy at that time was the Chung 2012 study.
Ah, yes. And do you remember the sample size on that one?
I do. That study evaluated a grand total of 10 dogs. 10.
Yeah, 10 dogs.
And 6 of those 10 dogs had a favorable response, but 4 had an unsatisfactory response. I mean, you cannot base a global veterinary consensus standard of care on an open-label study of 10 dogs.
You really can't. Without extensive therapeutic drug monitoring data mapping out the population pharmacokinetics, and without large controlled trials comparing it directly to phenobarbital, moving a newly diagnosed patient away from a proven therapy, even a toxic one like phenobarbital, was considered a massive, unjustified neurological risk.
I understand their hesitation now, but that brings us to the present day and the data that is actively filling that vacuum. Let's dive into the efficacy debate and look at the CITO 2024 Prospective trial.
This is where the clinical dogma really starts to fracture. The CITO study design is incredibly robust.
Yeah, they took 56 ASM-naive dogs with newly diagnosed idiopathic epilepsy, and the ASM-naive part is critical, right?
Oh, absolutely critical, because it means we aren't dealing with a liver that has already been enzymatically warped by prior phenobarbital exposure. These are clean metabolic slates.
Right, and the results they published were striking, a 76% responder rate. And we should probably clarify for everyone, in veterinary neurology, a responder is defined as a dog experiencing a 50% or greater reduction in seizure frequency.
Yes. And even more impressive than the 76% responder rate, 55% of these dogs achieved complete seizure freedom.
Over half of them just stopped seizing entirely.
Right. And those numbers represent a fundamental shift in how we must view this medication. A 76% monotherapy responder rate firmly places zonisamide in the exact same efficacy echelon as phenobarbital.
Which, if we recall the Booth study from earlier, sat around 85%.
Exactly. And it performs significantly higher than the historical monotherapy rates for bromide. But what makes the CITO study so compelling is the tightly controlled, stepwise titrated environment they utilized.
They didn't just pick a dose and cross their fingers.
No, they initiated therapy at a lower baseline dose. and meticulously titrated upwards based on strict clinical observation and therapeutic drug monitoring.
I noticed their dosing strategy. The mean maintenance dose for the dogs that achieved that greater than 50% reduction was 4.8 milligrams per kilogram every 12 hours.
Right.
And through that specific titration, they achieved a mean trough plasma concentration of 18.9 micrograms per milliliter. It seems like this slow, methodical titration is the secret to mitigating adverse effects while hunting for the individual dog's optimal therapeutic threshold.
It is the secret. The slow titration allows the central nervous system time to acclimate to the broad receptor blockade zonisamide imposes. If you aggressively load zonisamide or start at a massive dose right out of the gate, you overwhelm the patient's excitatory pathways.
And that results in profound, unacceptable ataxia and sedation.
Exactly, the dog can barely walk. But the cytomethodology proves that when zonisamide is introduced methodically to a neurologically naive patient, its efficacy is exceptional.
Okay, so the CYTO study gives us the controlled best-case scenario. It's a prospective, multi-center trial where everything is tightly managed. But clinical practice rarely looks like a prospective trial.
No, it's usually much messier.
Yeah, and this is why the brand new Auburn University retrospective, the ALAV-ERO26.pdf paper, is so incredibly valuable. This study looked at 207 dogs on zonisamide monotherapy.
Yeah, this isn't a controlled test track. This is raw, real-world data pulled directly from a massive clinical pharmacology laboratory's therapeutic drug monitoring database.
Exactly, test track versus rush hour traffic. In this real-world setting, they found a 59% overall responder rate, with 29% achieving complete seizure freedom and 30% showing a partial response.
And that contrast between the cytoprospective data and the Auburn retrospective data is a perfect illustration of clinical noise.
What do you mean by clinical noise in this context?
Well, in a retrospective study drawn from thousands of submitted lab samples, you are dealing with the chaotic reality of general practice. You have highly variable owner compliance, missed doses, inaccurate seizure logging by, stressed and sleep-deprived clients.
Plus the differing, sometimes flawed titration protocols of hundreds of individual referring veterinarians.
Exactly. And despite all that noise, despite the lack of controlled titration, despite owners forgetting to give pills, zonisamide still achieved a 59% responder rate.
Which is still better than bromide's 52% in a controlled setting. And furthermore, the Auburn researchers applied incredibly rigorous exclusion criteria to filter that data. They didn't just accept every sample that came through the door.
No, only 3% of all submitted zonisamide samples to their lab actually made it into the final study analysis.
Right, because they strictly excluded any dog with a hint of structural epilepsy, any dog on polypharmacy, and any dog over 6 years of age at the time of seizure onset.
And they did that to guarantee they were truly evaluating pure idiopathic epilepsy monotherapy. That rigorous filtering makes the 59% figure highly credible. It proves that even amidst the chaos of real-world veterinary practice, zonisamide monotherapy is biologically active and effective in the majority of cases.
But buried within the demographic breakdown of that 59% is a finding that could theoretically change the entire trajectory of veterinary neurology.
Oh, you're talking about the Labrador Retriever anomaly.
Yes. When I read this section of the Auburn paper, I actually had to read it twice to make sure I wasn't misunderstanding the statistics.
Pretty mind-blowing.
When they broke down the responder rates by specific breed, Labrador Retrievers had a staggering 92% responder rate. 11 out of the 12 Labradors in the monotherapy cohort responded dramatically to zonisamide.
Yeah, to put that in perspective, all the other breeds combined sat at a 58% responder rate.
A 92% efficacy rate in a single breed is an astronomical outlier. Are we suggesting that Labrador Retrievers have fundamentally different brains, or is this a metabolic quirk?
Well, this is where veterinary neurology begins to brush against the edges of pharmacogenomics.
Which is huge in human medicine, right?
Well, it's a standard part of practice. We know human patients with specific HLA-B alleles have a high risk of life-threatening skin reactions to carbamazepine, for instance.
Oh.
So in the case of the Auburn Labrador data, a 92% response rate is highly unlikely to be a mere statistical artifact of a small sample size. It suggests a distinct biological variable at play.
And what could that variable be?
Well, it could be pharmacokinetic, so how the dog's body metabolizes the drug. Or it could be pharmacodynamic, how the dog's brain receptors interact with the drug.
Let's explore the pharmacokinetic angle first. How is zonisamide metabolized in dogs compared to humans? And how could a Labrador be different?
In humans, zonisamide is heavily metabolized by a specific group of enzymes called cytosolic arylamine and acetyltransferases, or NET
Oh,
enzymes.
so okay, NAT enzymes.
But dogs, interestingly, generally lack these specific NAT genetic pathways. Because they lack them, dogs are forced to rely far more heavily on hepatic cytochrome P450 pathways to clear zonisamide, primarily CYP3A12 and CYP2C21.
Oh, I see where you're going with this.
Right. It is entirely plausible that Labrador retrievers, as an isolated genetic population, possess specific single nucleotide polymorphisms of genetic mutations in these CYP450 genes.
So if a polymorphism makes their CYP enzymes slightly less efficient at breaking down zonisamide, the drug would naturally accumulate to higher, more therapeutic concentrations in their plasma compared to, say, a German Shepherd given the exact same dose.
Exactly. It stays in their system longer, hitting higher troughs.
That would explain a higher serum concentration, but what if the difference isn't in the liver at all? What if the difference is in the brain itself, the pharmacodynamic angle?
Right. Because we know idiopathic epilepsy isn't just one disease.
It's a massive umbrella term for dozens of different genetic channelopathies that all result in the same clinical symptom, a seizure.
And that is actually the more compelling theory to me. If Labrador retrievers suffer from a specific genetic subtype of epilepsy, perhaps a specific mutation in a voltage-gated sodium channel gene like SCN1A, or a specific anomaly in their T-type calcium channels,
Their distinct neuronal architecture might be uniquely susceptible to zonisimade's specific mechanism of action.
exactly. The drug fits the Labrador's specific receptor mutation, like a key in a lock, resulting in that incredible 92% response rate.
If that hypothesis holds true in larger genetic studies, the implications are massive.
It would completely change how we practice.
Right. We are looking at a near future where a clinician doesn't just reach for a generic sequential flowchart of seizure medications. You look at the breed, or perhaps you run a simple genetic cheek swab panel, and you say, this patient has the SCN1A polymorphism. Zonisamide is statistically our absolute best first-line intervention.
We move from trial and error empirical medicine to highly targeted predictive precision medicine. It's the holy grail of neurology.
But to utilize zonisamide effectively, whether in a Labrador or a mixed breed, we have to talk about how we measure its presence in the blood. This leads us to the critical reevaluation of the therapeutic reference interval. Historically, veterinary neurologists have utilized a zonisamide reference interval of 10 to 40 micrograms per milliliter.
And the origins of that 10 to 40 microgram per milliliter interval are a perfect example of historical convenience overriding species-specific pharmacology.
We just made it up based on humans.
Basically, yes. That interval was not derived from large-scale, rigorous canine pharmacokinetic and pharmacodynamic mapping. It was directly extrapolated from human epilepsy data. We essentially borrowed a human metric, applied it to dogs, and adhered to it for over a decade.
And the Auburn retrospective definitively dismantles that borrowed metric. They didn't just guess a new range, they used the actual clinical data from 123 confirmed canine responders.
Right, dogs that were definitively proven to have a 50% or greater reduction in seizures on zonisamide.
And by analyzing the trough serum concentrations of those specific clinically successful dogs, they formally propose a new, significantly broader canine-specific reference interval of 10 to 55 micrograms per milliliter.
Extending that upper limit from 40 to 55 micrograms per milliliter is a vital update to our clinical parameters, and it aligns with the unique pharmacokinetic profile of zonisamide in the canine species.
Let's look at the baseline numbers for that profile. Zonisamide has excellent oral bioavailability in dogs, roughly 70%.
Which means 70% of the oral dose successfully survives first-pass hepatic metabolism and enters systemic circulation. That's very good.
And it has a half-life of around 15 to 17 hours in most dogs.
Yes, and that 15 to 17-hour half-life is the sweet spot for clinical compliance.
Because it perfectly allows for every 12-hour dosing without dropping below therapeutic trough levels before the next pill is given.
Exactly. And because of that specific half-life, the drug reaches steady-state concentrations in the blood in about 4 to 5 days.
Compare that to the weeks or months it takes bromide to reach steady state without a loading dose. I mean, you can start zonisamide on a Monday and know exactly where your serum levels are sitting by Friday.
It's incredibly convenient for rapid adjustment. But the most alarming finding in the Auburn study regarding pharmacokinetics wasn't the half-life. It was the linear regression analysis comparing the administered oral dose to the actual plasma concentration achieved.
Oh man, the regression analysis. This is the data point that should completely change how general practitioners prescribe this drug. When they mapped the dose given in milligrams per kilogram against the actual serum concentration measured by the lab, the R-squared value was only 0.41.
Yeah, an R-squared of 0.41 is a weak to moderate correlation at best.
When you look at the scatter plot in the paper, it is literally just a massive cloud of data points. To put this in practical terms for the clinician in the exam room, you can have two dogs, identical in age, identical in weight, and you prescribe both of them the exact same standard dose of 5 milligrams per kilogram of zonisamide twice a day.
And one dog's liver will process it rapidly, resulting in a subtherapeutic serum level of, say, 12 micrograms per milliliter.
Well, the other dog's liver will process it slowly, resulting in a serum level of 45 micrograms per milliliter.
Exactly. The clinical implication of that scatter plot is unequivocal. Empirical dosing is biologically inadequate. You cannot pick a milligram per kilogram dose from a textbook, send the dog home, and blindly trust that you have achieved a therapeutic serum concentration.
Because the dose-to-plasma correlation is so profoundly variable, strict therapeutic drug monitoring, pulling blood and measuring the trough concentration is absolutely mandatory. You are flying completely blind without it.
Completely blind. You have no idea if you're underdosing or overdosing until the dog seizes or becomes toxic.
I completely agree that we need to measure the trough levels, but I need to play devil's advocate regarding this new upper limit.
Yeah.
If we officially widen the target range to 55 micrograms per milliliter, aren't we just inviting dose-dependent toxicity? I mean, 55 is significantly higher than the old human ceiling of 40. With drugs like phenobarbital, if you push the serum level past 35 milligrams per liter, you are practically guaranteeing profound sedation and rapid hepatic destruction.
Right.
So how do we justify pushing zonisamide serum levels that high in a canine patient?
Your caution is completely valid, as it is rooted in our historical trauma with phenobarbital toxicity. But zonisamide behaves entirely differently at high serum concentrations.
Okay, how so?
The justification for pushing serum levels to 55 micrograms per milliliter lies in the intersection of individual neurological requirement and patient tolerability. Some dogs suffer from highly refractory aggressive cortical firing. They biologically require those higher plasma levels to maintain seizure freedom.
And they can actually tolerate it.
Yes. Crucially, the aggregate data from both the Cyto Prospective trial and the Auburn retrospective demonstrates that many canine patients tolerate those higher levels, 45, 50, even 55 micrograms per milliliter, without severe or dose-limiting adverse effects.
So we are shifting away from treating the number on the lab report and moving toward treating the patient in front of us.
Exactly.
If I have a patient with a trough serum level of 48 micrograms per milliliter, and the owner reports the dog is entirely seizure-free, and their only adverse effect is a slight transient lethargy for an hour after the morning dose, I shouldn't panic and reduce the dose just because 48 is higher than the old limit of 40?
Absolutely not. That is a clinical success. The reference interval is a topographical map. It's not a set of concrete walls.
I love that. The map, not the wall.
Right. And the recognized dose-dependent adverse effects of zonisamide sedation, ataxia, transient inhabitants are generally mild. The Cyto study specifically noted that when adverse events like decreased appetite or slight hind limb weakness occurred, they often resolved spontaneously as the central nervous system acclimated to the drug over a few weeks.
Or they were easily mitigated with a minor temporary dose reduction.
Exactly. These side effects are fundamentally different from the irreversible progressive organ damage we fear with long-term phenobarbital administration.
Which provides the perfect, unavoidable transition to the elephant in the room: hepatotoxicity. For a decade, the paralyzing fear of destroying a dog's liver has kept zonisamide locked in the second-tier cabinet.
It really has.
We have to demystify this safety profile if we're going to advocate for its use as a first-line monotherapy. Where did this intense fear originate?
The apprehension surrounding zonisamide and hepatotoxicity does not stem from large-scale population data. It stems from a few isolated yet undeniably terrifying case reports published in the veterinary literature roughly a decade ago.
You're talking about the 2011 papers.
Yes, specifically the Miller 2011 paper and the Schwartz 2011 paper. They documented cases of apparent acute idiosyncratic hepatic necrosis in dogs receiving zonisamide. Concurrently, there was a 2011 report by Cook documenting a case of severe renal tubular acidosis.
And when a clinician reads a detailed case report of a dog suffering rapid fatal liver failure on a relatively new medication, it leaves an indelible psychological impact.
Oh, a massive impact. That kind of anecdotal trauma dictates prescribing habits across the entire profession for years.
It creates a powerful negativity bias. You forget the hundreds of dogs doing well, and you only remember the one dog whose liver necroticized.
Right, but anecdote is not data.
And we finally have the data to contextualize those fears. I want to look closely at the Smith 2022 paper. This is a massive, multi-center retrospective study of 384 dogs, specifically designed to analyze the true clinical incidence of zonisamide-induced hepatopathy.
And the findings are incredibly reassuring.
Very reassuring. Acute clinical hepatopathy is exceptionally rare. Out of 384 dogs evaluated, only 2 developed acute clinical hepatopathy.
That is an incidence rate of 0.52%.
0.5%. Furthermore, the data reveals that when this acute reaction does happen, the timeline is highly specific and predictable. It almost universally occurs within 13 to 16 days of initiating the treatment.
To understand why it happens in that specific 13 to 16-day window, we must differentiate between dose-dependent toxicity, which is, the slow, predictable cellular damage we see with chronic phenobarbital use over years, and idiosyncratic toxicity.
Right.
Idiosyncratic reactions are unpredictable, non-dose-dependent, immune-mediated, or metabolic hypersensitivity reactions. Remember earlier when we said zonisamide is a sulfonamide derivative?
Yes, I remember.
Well, in human and veterinary medicine, sulfonamides are notorious for triggering rare, immune-mediated hypersensitivity reactions via the formation of reactive metabolites. These metabolites act as happens, triggering a massive immune cascade.
So the acute hepatopathy occurring squarely at the 2-week mark perfectly fits the pathophysiological profile of a classic, rare, delayed, cell-mediated hypersensitivity reaction.
Yes, it is the immune system suddenly attacking the liver because the zonisamide metabolites have bound to the hepatic cells, making them look foreign.
Wow. So it is not a slow, insidious poisoning of the liver tissue by the chemical itself. It is an acute, catastrophic immune event.
That is the exact mechanism. And understanding that mechanism is liberating for the clinician. With chronic phenobarbital use, the liver damage is akin to a slow rust. The enzymatic induction and the oxidative stress are happening constantly. It is practically a biological guarantee that the liver will sustain damage if the dog lives long enough on the medication.
But the 0.52% idiosyncratic risk of zonisamide is entirely different. I think of it like this. The idiosyncratic risk of zonisamide is a sudden, unexpected lightning strike.
A lightning strike, yes.
It is incredibly rare, 0.5%, but if it hits, it is devastating. Contrast that with phenobarbital, which is the slow, guaranteed rust. I will take the 0.5% lightning strike risk over the guaranteed rust every single time, especially when the Smith data proves we know exactly when the storm rolls in.
And the predictability of that 13 to 16-day window empowers clinicians with a highly specific preventative clinical action plan. Because we know the timeline of this idiosyncratic immune reaction, the safety protocol becomes absolute.
What's protocol?
You obtain a comprehensive baseline serum chemistry panel, paying specific attention to ALT and ALP before initiating zonisamide therapy. Then you mandate a recheck of those specific liver enzymes at week 3.
So right after that danger window closes.
Exactly. If the dog clears that critical 2 to 3 week idiosyncratic window without massive spikes in liver enzymes or clinical signs of illness like icterus or acute vomiting, the probability of long-term, safe hepatic function is exceptionally high.
Okay, but what about chronic long-term liver effects? The lightning strike happens at 2 weeks. What happens after 2 years? The Smith study evaluated that as well, didn't they?
They did. They analyzed 117 cases that were chronically administered zonisamide for a median of 20 months. And some of these dogs were on the drug for up to 94 months.
That's a long time. Did they see liver failure?
They did observe some mild enzymatic elevations. About 8.6% of dogs developed an increase in ALP, and 5.1% developed a mild increase in ALT.
But here is the critical clinical takeaway. 0 dogs in the chronic study showed clinical signs of liver disease. Less than 10% get mildly elevated enzymes, and none actually develop clinical hepatic failure.
That is a fundamental distinction that every prescribing clinician must grasp. An elevated ALP or ALT on a chemistry panel is a biomarker. It is a signal of cellular stress or enzymatic induction. But a mild elevation is not synonymous with clinical hepatic failure or decreased functional hepatic mass.
The liver is an incredibly resilient organ. As the Smith paper meticulously points out, Those subclinical abnormalities in liver enzymes were noted without any concurrent clinical signs of liver disease. No hypoalbuminemia, no decreased BUN, no icterus being reported over a median of nearly 2 years of continuous therapy.
Exactly.
When you synthesize this vast safety data from the Smith paper with the striking efficacy data from the Saito and Auburn papers, the historical argument that zonisamide is too dangerous or unproven to be a first-line monotherapy completely collapses.
It really does. It is safe, it is highly effective, it reaches steady-state pharmacokinetics in 4 days, and you can conveniently dose it twice a day.
So the logical question is, why wouldn't you use it for every single newly diagnosed epileptic dog?
Well, because we practice in reality, where cases are often referred to us only after they have become refractory to other medications, and polypharmacy is a grim, unavoidable reality.
Which brings us to the most complex pharmacological dynamic of this entire deep dive: the metabolic traffic jam of polypharmacy. We have to explore the dangerous enzymatic interplay between zonisamide and phenobarbital. This is what I brought up in the intro.
And this is undoubtedly the most clinically vital dynamic we will discuss today, because misunderstanding it can easily kill a patient.
Yeah, let's break it down. When a dog on maximum tolerated doses of phenobarbital continues to experience cluster seizures, zonisamide is frequently selected as the secondary add-on medication.
Right. But introducing these two specific molecules into the same hepatic system creates a metabolic tempest driven by cytochrome P450 dynamics. Let's start by establishing the foundational knowledge proven by the Oredo 2008 paper. Phenobarbital is one of the most potent known pharmacological inducers of hepatic cytochrome P450 enzymes, particularly the CYP3A and CYP2C subfamilies.
Phenobarbital essentially acts as a systemic alarm, telling the liver we are being flooded with chemicals, build more metabolic factories immediately.
That's a great way to put it.
It massively upregulates the transcription and translation of CYP enzymes, dramatically increasing the liver's overall capacity to process and eliminate xenobiotics. So what happens when you introduce zonisamide into a liver that has been hyperinduced and supercharged by phenobarbital?
The Oredo study demonstrated that the phenobarbital-induced liver aggressively attacks and metabolizes the newly introduced zonisamide. The zonisamide half-life plummets. Its maximum serum concentration, or Cmax, drops significantly.
The area under the curve, or AUC, which represents the total drug exposure over time, shrinks dramatically.
Yes. The zonisamide is being cleared out of the body at top speed before it can even reach the brain.
The mechanism is straightforward enzyme kinetics. Because zonisamide structurally relies on those very same CYP3A and CYP2C enzymes for its own metabolic clearance, the massive surplus of enzymes created by the phenobarbital simply chews through the zonisamide molecules.
This is why neurologists have historically known and taught that if you are adding zonisamide to a dog already receiving phenobarbital, you must significantly increase the zonisamide starting dose, sometimes doubling it to 10 milligrams per kilogram, just to achieve basic therapeutic serum levels.
You are fighting against a hyperactive liver. And the Oredo study demonstrated another critical, frustrating timeline. If you decide to take the dog off phenobarbital, it takes up to 10 weeks for this phenobarbital-induced enzymatic upregulation to wear off.
Yeah, that is a massive 2.5-month window of altered, hyperactive metabolism that a clinician must carefully navigate with frequent therapeutic drug monitoring if they are trying to transition a dog off phenobarbital and onto zonisamide monotherapy.
Because the clinical danger during that transition period is that as the phenobarbital slowly leaves the system and the CYP enzymes slowly downregulate back to baseline, the high dose of zonisamide you were forced to use previously will suddenly become a massive overdose,
leading to severe toxicity if you aren't proactively reducing it.
So we've established that phenobarbital eats zonisamide. The veterinary community largely understood that, but then the Mahan 2024 paper was published, and it dropped an absolute pharmacological bombshell.
The unexpected inverse interaction.
Yes. The Mahan researchers didn't just look at what happens to the zonisamide levels. They looked at what happens to the phenobarbital levels when you add zonisamide to a dog already taking stable doses of phenobarbital.
And the results are terrifying for anyone who prescribes these drugs blindly.
They really are. Adding zonisamide actually causes serum phenobarbital concentrations to spike. In 9 out of 10 dogs in their study, the phenobarbital levels increased. And in 5 of those dogs, the phenobarbital levels skyrocketed into recognized hepatotoxic trough ranges, greater than 35 milligrams per liter.
These dogs presented with severe ataxia, profound sedation, and massive acute liver risk.
And why does this happen?
It is a brilliant, albeit dangerous, real-world example of competitive enzyme inhibition overriding enzyme induction. It creates a complete metabolic traffic jam. While the phenobarbital has induced massive amounts of CYP enzymes, expanding the capacity of the liver, zonamide arrives and acts as a high-affinity competitive inhibitor for those exact same shared metabolic pathways.
I see.
Even though there are more enzymes present, the zonisamide molecules effectively block the phenobarbital molecules from binding to the active sites of the CYP2C and CYP3A enzymes.
I want to make sure the clinician listening to this has the exact mechanism clear in their mind. Phenobarbital induces the liver to clear drugs faster. Because of this, the zonisamide is chewed up rapidly, so we as clinicians give massive double doses of zonisamide to compensate.
Right, we double the dose.
But at the exact same time, all that extra zonisamide we are pouring into the dog is aggressively binding to the CYP enzymes, acting as a competitive inhibitor, and physically blocking the phenobarbital from being metabolized.
Yes.
The phenobarbital is trapped in the bloodstream, continuously accumulating with every subsequent dose until it reaches toxic liver-destroying levels. It is a pharmacological tug-of-war where the patient's liver is the rope.
It is a highly precarious pharmacokinetic dynamic. If a clinician is unaware of this competitive inhibition, it is a clinical nightmare. This dynamic fundamentally changes the protocols for handling polypharmacy with these two specific drugs.
So let's outline a common clinical scenario. You are evaluating a dog currently on a high-end therapeutic dose of phenobarbital, maintaining a trough level of 30 micrograms per milliliter. The dog's liver is functioning, but the seizures are poorly controlled. The clinician decides to add Zonisamide at the historically recommended higher dose for dogs on phenobarbital, say 10 milligrams per kilogram twice a day.
Because of the Manon 2024 data, we now know exactly how that scenario ends. The zonisamide floods the system and clogs the active sites of the CYP enzymes. The phenobarbital level isn't going to stay safely at 30. Over the next 2 weeks, it is going to climb to 38, 40, or 45 micrograms per milliliter.
The owner is going to call you in a panic because the dog is suddenly profoundly sedated, unable to walk without knuckling, and completely lethargic. And the liver is going to be under immense acute toxic stress.
The clinical mandate derived from the Hanaba paper is aggressive, proactive therapeutic monitoring. When adding zonisamide to a patient already stabilized on phenobarbital, the clinician must assume and expect the phenobarbital serum levels to rise.
You cannot wait for clinical signs of toxicity to appear.
No, absolutely not. You must proactively recheck the phenobarbital trough level within 2 to 3 weeks of adding the zonisamide. And you must be mentally and clinically prepared to drastically reduce the phenobarbital dose to prevent life-threatening hepatotoxicity and profound sedation.
The most vital clinical distinction from the Mahan study is recognizing the true source of the toxicity. When you see a dog stumbling around the exam room 3 weeks after you prescribe a new drug, human nature and clinical instinct tell you to blame the new drug.
Right, you assume a zonisamide toxicity.
But the new drug didn't poison the dog directly. The new drug competitively inhibited the metabolic pathways, causing the old drug to become highly toxic. It's zonisamide-induced phenobarbital toxicity.
That's a perfect way to phrase it. This specific scenario highlights exactly why empirical dosing in neurology, without strict therapeutic drug monitoring, is akin to practicing veterinary medicine in the dark. You simply have to measure what is actually happening in the serum.
The intersection of the Arito and Mahan papers is a masterclass in cytochrome P450 dynamics. It proves that we cannot just stack anticonvulsant medications on top of each other and hope for the best. We must deeply understand their interactions at the molecular and enzymatic level.
Absolutely.
Let's pull all of these complex pharmacological and clinical threads together. We have covered a tremendous amount of ground today.
We really have.
The central takeaway for the clinician listening is that zonisamide is no longer just a backup player waiting for phenobarbital to fail. The days of sidelining it due to insufficient evidence are officially behind us. The robust, tightly controlled data from the Sato Prospective trial, combined with the real-world massive dataset from the Auburn retrospective, confirm that zonisamide is a highly effective, neurologically sound monotherapy.
It rivals, and in many ways exceeds, the utility of our historical gold standards. Furthermore, the vast epidemiological dataset from the Smith retrospective unequivocally proves that its safety profile is vastly superior to the historical fears generated by isolated case reports.
The risk of acute hepatopathy is roughly 0.5%.
Yes, exactly. Providing clinicians understand and respect the strict 3-week monitoring window for that idiosyncratic hepatic necrosis, utilize the newly proposed, broader 10 to 55 microgram per milliliter reference interval to titrate to clinical effect via trough monitoring, and carefully, proactively navigate its metabolic tug-of-war with phenobarbital, zonisamide emerges as an exceptionally powerful, safe, and versatile tool in our neurological arsenal.
It truly is a new era for canine epilepsy management. We are moving away from fear-based prescribing and moving toward targeted, data-driven medicine. And I want to leave you with a final provocative thought that builds on what we discussed earlier regarding the Auburn demographic data. Think back to their finding that Labrador retrievers had a staggering 92% response rate to zonisamide monotherapy.
Oh, that statistic still amazes me.
Could this single data point be the dawn of true widespread pharmacogenomics in veterinary neurology? We already know that in human neurology, a simple genetic test for specific HLA-B alleles can prevent life-threatening skin reactions to carbamazepine. What if dogs possess similar, easily testable genetic markers? Single nucleotide polymorphisms in their CYP450 genes, or specific anomalies in their voltage-gated sodium channels that perfectly predict drug efficacy. As you analyze your next newly diagnosed epileptic patient in the exam room, consider that we are rapidly moving away from a rigid, one-size-fits-all, step-by-step algorithm.
We might be moving toward a future where a simple rapid cheek swab determines a dog's specific genetic and metabolic profile, and their genetic code dictates their very first, highly targeted, highly successful prescription. That is the ultimate goal of modern pharmacology, to move away from empirical trials and unpredictable errors and move toward predictive, personalized success. The clinical data we have synthesized today represents a massive foundational leap forward in that journey.
Thank you for listening. The titles for the reference papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging.